Center. His research has focused on improving the care and outcomes of critically ill patients with sepsis and respiratory failure, with special emphasis on the problems facing older patients in the ICU. Problems such as weaning from mechanical ventilation, delirium, and cognitive impairment in the ICU, neuropsychological deficits, post-ICU care, and the quality of death in the ICU. Dr. Ely has written or co-authored more than 250 articles, book chapters, and editorials. As the founder of the Vanderbilt ICU Delirium and Cognitive Impairment Study Group, he currently serves as the principal investigator for the coordinating center's ongoing clinical trials in sedation and delirium and post-ICU cognitive impairment. Dr. Ely designs and leads a team of investigators in conducting both large cohort studies and randomized controlled clinical trials seeking both better understanding and management of critically ill patients in the ICU. Among other studies, Dr. Ely is currently the principal investigator of 2 large NIH-sponsored and VA-sponsored cohort investigations in ICU patients, with a focus on delirium and sedative and analgesic drug exposure and acquired cognitive and functional impairment in survivors of the critical illness. He is especially thankful to have the privilege of working with such a talented and interdisciplinary team of professionals from dozens of different training backgrounds to conduct research in such an important public health domain. He is married to Dr. Kim Ely, a surgical pathologist at Vanderbilt, with whom he has 3 lovely daughters who are together the pride of his life. Dr. Wesley Ely.
Thank you so much. It's a privilege to be here today, and I appreciate all of you in giving me some time of your precious day. Let me see, does this microphone work okay? All right, I figured my big mouth would work. We don't need 2 microphones for me. My wife would get a big kick out of that one. It's a special thing to be able to come to speak to people who are interested in bioethics and who take this as seriously as I think we all need to take it. And it's a kind of a scary time in our world right now, isn't it, with all that went on yesterday in Boston. I ran in Boston a couple of years ago and had that joy and elation crossing that last point too, going down Bolston Street, and could just brought me to tears last night thinking about what happened there. So we have to enter today, a new day, the sun rising, thinking of those people, the suffering that they're undergoing, and how we might make a difference in our lives for the people that we come across. And the talk that I will go through with you today over the next few minutes hopefully will help all of us to address where we are in our lives with regard to faith. Faith at the end of life is something that is just a continuation of what we've been pursuing the entire period of our life, of course. But for some reason, I as a physician watch a lot of people get really thrown off kilter when it comes time to death. So that is what I'm going to discuss with you today. I have a couple of, somebody really is in pursuit of this person on this cell phone here. It brings up this pursuit thing, though it brings up what my morning reading was this morning. I was reading Flannery O'Connor's book, a short story called Parker's Back. Anybody ever read Parker's Back? Pretty amazing story. It was her last short story to ever publish before she died of lupus at the age of 35 many years ago. You know, she's one of the greatest short story writers of the 20th century. And Parker's Back is a short story that is really about God's pursuit of man. Anybody ever read Tozer's book, Pursuit of Man and Pursuit of God? Fabulous book. Just reminds us of this verb pursuit. And so this morning, all during the hours in which I was reading this book, this story, Parker's Back, I kept thinking about how God is in pursuit of all of us, and how perhaps the story that I will tell you today really can help put in context the long-term goal of this pursuit. if he is in pursuit of us, and if we are to lead a life that will be someday rewarded by being in his presence for the remainder of eternity, then I think it is incumbent upon us to put death into context, since it is merely a continuation of this journey that we are on, and that will be the topic of this morning. I begin with a prayer that is one that I say whenever I do a silent retreat in South Louisiana on the Mississippi River. It's the Manresa prayer, the gift of life. And you can pray it with me if you wish. In the name of the Father, and the Son, and the Holy Spirit. Lord, teach me not to hold on to life too tightly. Teach me to take it as a gift, to enjoy it, to cherish it while I have it, but to let go gracefully and thankfully when the time comes. The gift is great, but the giver is greater still. You are the giver, and in you is a life that never ends. I was startled last night when I went back to my hotel room and I got an email from this guy named Bruce Kimsey. He won't mind me using his name. He asks me to whenever I can. He is a guy who follows our delirium work in the ICU because he himself is an ICU survivor. And after his ICU experience, he left with a pretty bad situation of acquired dementia, which is my area of research. People coming into an ICU mentally intact, leaving an ICU circumstance with a disease that really resembles Alzheimer's. And that happened to him. And he was telling me about earlier in his life when, prior to the ICU experience, he had pursued medicine and then pursued law, and with his combined degree had set out to do what he could to improve the lives of others. But that after he got out of the ICU and he had this acquired dementia, it really changed his focus more on these kind of the closure of the loop of his life. And he was telling me how he really struggled with his faith and how he envied me for having my faith and how he didn't seem to be able to get his back. So keep in mind as we go through this talk today, all of those people, maybe many in this room, or people in this room know others who are struggling with their faith and having a truly difficult time putting all of this into context. I want to make this disclosure to you, much like I would in any talk where I would disclose any potential conflicts of interest from the perspective of industry. My disclosures are that I am an ICU physician, and so as a physician in the ICU, I lose about 1 out of 3 of my patients to death. And so that is something that I come into contact with on a regular basis. And in addition to that, I want to disclose that I'm Catholic and that my opinions are based on Scripture and on the teachings of the Church, most of which will be cited in this lecture today, and my anecdotal experience of caring for thousands of dying people who come from all faiths, beliefs, and non-beliefs. I have no incentive to hasten death and the incentive of heaven to preserve life and God's will. The reason I make that disclosure to you is that I want everybody in the room to know that I'm sure there are people in here of different faiths, and I'm sure there are agnostics and atheists in the room too. And I want you to know that I have a deep respect for your journey and where you are, and I don't want you to think that I assume that all the things that I say up here are always correct and right, and that they are, if in conflict with yours, that I don't respect your belief system dramatically too. Whether you be Muslim, Hindu, Buddhist, atheist, whatever it is, I have a deep respect for your path to God. And in fact, so did the former Pope who just retired, Pope Benedict, when he was interviewed by Seawald for the book-long interview that many of you probably have read, The Salt of the Earth, when he was still Cardinal Ratzinger prior to becoming Benedict XVI. Seawald asked him at the beginning of his interview, how many paths are there to God? And the soon-to-be Pope said, as many paths as there are human beings. And it kind of blew Seawald away because he thought, you know, this guy is the leader is sitting in Peter's chair eventually when he wrote this down. And he could have said one, or he could have said a couple, but he said as many paths as there are human beings. And so all of us in this room know that to be the case. And I just wanted to disclose that I respect all of your different journeys. Saint Gianna Molla, who is a modern-day saint, and the reason that I quote her is because we tend to think of saints as kind of dusty statues, but she was a modern-day Italian, and she gave her life for her newborn. There's a very heated case out in the West right now where a hospital was in conflict with the decision about a mother and her unborn baby about the interventions that were to take place for that mother. I think many of you have probably read about that. But the church supports saving the mother's life if the pregnancy would endanger her life. And we always expect that we need to keep the mother alive if at all possible. St. Gianna actually took the opposite stance and sacrificed her life for her baby, who is now a grown practicing physician in Italy. And she is now sainted because of this and many other actions and some miracles that were attributed to her posthumously. She wrote, "Physicians and other healthcare professionals have opportunities that priests do not have. And our mission does not end when medicine is no longer of help. There still remains the soul, which must be brought to God. Jesus says, 'Whoever visits the sick is helping me.' This is a priestly mission." Last Wednesday night, I was in Haiti, and the priest, Father Guy Dumont, said to me, "Wes, I want you to come and see a girl who was shot tomorrow. I'll bring you to her. We need to see if we can help her." And I think about these words of St. Gianna all the time and hope that I can do any justice whatsoever to what she's talking about, this vocational aspect of my medicine practice. And many of you in the room in healthcare perhaps also pursue the same thing on a regular basis. Anyway, he said, "Let's go tomorrow," and it was just past 10, and I said, "No, let's go now." And it's dark in Haiti when there's no electricity, and it's difficult when there's no road. But we got in his Land Rover, and we went over the non-roads, the rocks, and the sides of the mountains to get to this girl in a shack about as big as one of these tables, these big round tables, maybe 1.5 of them. And there were chickens in the little shack, and she was under a mosquito net. And this 16-year-old beautiful girl lying face down on this cot, they pulled back her cover, and she had these 6 or 7 bone-deep wounds on her rear end and sacrum. Because of that, they had her face down, and I lifted up her legs, and blood just dripped down from her knees onto this cot where her knees had, over the past 60 days, just day in, day out, eroded her skin and tissue to where it was down to just the patella, just the bone showing on both of her knees. As I lifted her legs to understand the extent of her injury, she screamed out in pain. And I've only told this story, this is the second time. I told it once yesterday. Actually, 2 people in the room were there. And sorry if you're going to get bored today hearing the same stories again. But anyway, I walked to the head of her bed, put her legs down, and I said to her, "What is your name?" And she said, "My name is Cleet Simeon, and I have a question." And her question turns out to be central to our path in faith and to how we need to respond to trials and tribulations in our life, including end of life. So this point about St. Gianna giving up her life in service of her unborn baby, or Cleet Simeon's question, which I'll come back to at the end of the talk, and the stories that I'm about to tell you in the context of end of life, all have the same theme. And for you, they rest in this question: where will you turn when faced with a trial that you don't think you can handle on your own? And how have you nurtured your faith, like nurturing the soil in a garden, to create a situation where you can flower and bloom in that situation where it seems overwhelming, whatever it is that you're posed with, such as Boston yesterday. So JP2 wrote in Evangelium Vitae, with regard to things, but even more with regard to life, man is not the absolute master and final judge, but rather the minister of God's plan. Human life is sacred from its beginning to its end. And I want to make certain that for the Christians in the room, but even for the non-Christians in the room, that we understand what Jesus said and what is recorded in the Gospels about how he equated death and baptism. Most of us are much more familiar with how to handle baptism, or spiritual moments towards the beginning of life, than we are able and equipped to handle the death. But Jesus says in Luke, there is a baptism with which I must be baptized, and how great is my anguish until it is accomplished. What's so anguishing about baptism? Little babies, young people getting baptized. Of course, he's talking about his death. His bloody, awful death hanging on wood, which is not disputed, even for the non-Christians in the room. Nobody is denying that Christ existed or that he died on the cross. What's questioned, of course, by many different people is whether or not he was divine and rose from the dead 3 days later. That's the part that people argue about. But the historicity of this human who died on the tree is not in question. Josephus and many other historians have well established that these things occurred. And he went on to say again, you will drink the cup I drink and be baptized with the cup I am baptized with. The point I'm making is that we all too often fail to equate death with baptism as a form of baptism. And if you view a river, and you go in one bank of the river and come out the other bank, that's what Christ is saying, basically. Baptism towards the beginning of life is met with another type of baptism on the back end of life to go into the hereafter. And so, when you start thinking about it like that, you can start processing that death is not always such an awful situation. It brings with it a lot of difficulties, which I'll get to in a minute, but this is, to me, a very hopeful component of death. Now, for people in the room who are agnostic and atheist, and especially for people in the room who are Christian and who will discuss, or Jewish, I'm quarter Jewish. My grandfather, who I respected more than anybody in my life, was Bug Cohen, a Lithuanian Jew who came over, he and his parents, many years ago when Lithuania was having big troubles. No matter who we are, we will come into context with people who don't believe that there's a God, and they then might have difficulty understanding the sacredness or the value of life. And to those people, I always turn to the situation of natural law. This is the universal law based upon rational nature of us as humans. It is not based upon religion, and it applies to all of us regardless of those faith backgrounds. Natural law is inscribed in the human heart, known by human reason, and against killing in any form. Twain wrote, the universe is governed by strict and immutable laws. Twain, who at the end of his life was having a big struggle with faith, as you know, very, very depressed person. And these strict and immutable laws are referenced by Francis Collins, who is now, as we speak, the director of the National Institute of Health, which is where I get my funding for all of this research that we do at Vanderbilt University, where I'm a professor. And Francis Collins wrote, caring for another in a desperate situation is the most meaningful of human experiences, the true north, and derives from natural law. You can see all these references and go read about natural law if you haven't studied this. But I especially like Francis Collins' example, because he was an atheist and agnostic years earlier in his life when he started the Human Genome Project. I mean, this guy is a world-renowned geneticist and completed the Human Genome Project, and now continues to include natural law even in the context of his Christian teaching as well. And this book, by the way, that Francis Collins wrote, The Language of God, is something you ought to look up. It's called The Language of God. It's an absolutely fascinating book written by this world-renowned geneticist. And on the cover of the book, he has a stained glass window. But the only thing is, it's not stained glass. It's a picture of DNA. And it looks exactly like stained glass, which obviously you can tell what his point is by doing that. But death is and has a very evil component to it as well, as we saw yesterday. Death in general is a consequence of the fall, and in a sense it is punishment. Our opinions about death are often very imprisoning, but death takes and it gives. The first part of my talk today has been about how it can give, but it also, of course, takes. One of the most important words in theology is the and. This written by the Vanderbilt director of student Catholic and Christian missionary on Vanderbilt University. He wrote to me, "Death is both evil and a good release." This both and experience is true in that death may lean one way more or another, but there's always something of both in every death. We're never completely sad about any death, nor completely happy. I think that was brilliant the way he put that. My friend Richard Hermes, who's a Jesuit, we're going to hear later today from at least one more Jesuit I know, maybe others, wrote, "Christian tradition has the bon amours, the good death. The litany to St. Joseph specifically makes a request for a good death." And I talk all the time in the ICU about good deaths. I say to my patients and their families, I can't cure you if that's the situation, if you have incurable cancer, but I can help you on your path to a good death. In fact, last week I had a lung cancer patient come in. He had stage 4 lung cancer, obviously incurable. He'd been getting radiation and chemotherapy for 6 months, and he came in with this huge GI bleed. And after we got the GI bleed contained, I was sitting there talking to him, and he said, Doc, I want to know, how long do I have to live? And I had just met him that morning, and I had not had any discussions with him about what others had told him. So to be protective of what others had said, I said, my answer probably would be about the same as what all your other doctors have told you. And I planned to pursue that. I didn't want to evade him or anything, but I wanted to see what he said. He said, well, no doctor's ever talked to me about how long I can live. 6 months into chemo and radiation. Now, he could have had that conversation, maybe he just didn't remember. I don't want to judge what others did or didn't tell him. But the fact was that he didn't know anything about how long he could live. So one of the things at the end of this talk I'm going to teach you are 8 evidence-based points about important end-of-life communication. So at the end, I've extracted from the literature 8 salient take-homes about end-of-life communication. And one of them is that when you are asked how long you can live, is to flip it. It's very difficult for me to tell someone how long they can live. I don't have a crystal ball. I don't know the answer to that. And when we're asked that question, we feel very boxed in. We don't know how to answer it, so we kind of squish and squirm. But if you flip it, it's a lot easier. Mr. Smith, I don't know how long you can live, and I hope you're alive in 6 months, but let me say this. With stage 4 lung cancer and acute GI bleeding, as you've just had, it would not be surprising with all the other things going wrong with you if you were to die in the next week or month. And I want you to be ready for that. I want you to think about the fact that, and prepare for the fact that if another situation occurs like this, you could die fairly quickly. And so get things in order for you and your family and your relationships. As I was telling him all this, the family was over in the window box. I'd never met them at all. And they were listening, pretty intently to all this. And then I did one other thing in that conversation with him that is one of the other 8 end-of-life communication tenets that I have incorporated and that we teach at Vanderbilt University. And I said, I need to know, and I was about to take a spiritual history, but before I do that, let me preface it with how we have worded this, so you'll pay attention to the words. We teach, and I worked with the deans of Vanderbilt to make sure that the medical students got a teaching on spiritual history. We didn't include spiritual history for many years to the medical students. I was never taught to take a spiritual history when I was at Tulane University, or at Barnes Jewish, or at Wake Forest, all the other places I've been. But we teach them how to take a sexual history, and we do it in a non-confrontational way, and we teach them to say, do you have sex with men, women, both, or neither? Just straight down the line, non-judgmental, people feel comfortable answering that question, and that way you can get the information you need to provide good care. So much the same way, I asked him, do you have any spiritual values that you want me to know that would affect your medical decisions? You see, non-judgmental. Do you have any spiritual values that you want me or your healthcare team to know that would affect your medical decisions? And so we had that conversation. Yeah, oh yeah, thank you for pointing that out. They actually printed that. This yellow handout for you has this story that I'm telling you now. It has that spiritual history on that yellow handout. I forgot that you had that. I'm the president of the Nashville Catholic Medical Association. And each month in Nashville for the CMA, we have a newsletter. And so this was the president's address last month. Sister Mary Diana, get this name, Sister Mary Diana, Sister MD. She's a doctor. She's actually a physician. So Sister MD, she makes me write these things every month. I wouldn't do it, but she says, oh, we got to hear something from the president, so whatever. I wrote that one last month, and it includes this story. But the other part of that story I'll go ahead and tell you now is that once all that was over, I went out into the hall, and the family scurried after me and said, oh, God, we got to talk to you. I said, okay, well, what is it? What do you want to know? I thought they were going to yell at me about, telling him he could die too soon. They said, no, we just want to tell you how thankful we are that Papa has a Baptist doctor. So I said, well, it's a real privilege, too. Anyway, these are things that come up in the context of end of life. And then you think about this passageway. Consider death as a passage to eternal life. It's baptism through the river. Our true birthday. Saints' birthdays are their death days. Did you know that? If you ask a saint for what is a saint's birthday or feast day, it's usually their death day when they were martyred, if that's the case. We can be grateful and thankful when death finally comes to a person who's in great agony, who had been suffering for a long time. This guy right here in the ICU was my patient. I was on rounds, and the nurses said, come quick. And when they say that, buddy, I run, because they don't use the word quick unless it's a big deal. I walked in, he had vomitus all over his chest. He was a bone marrow transplant, totally immunosuppressed. I had to intubate him through all of that. It was all down in his trachea and his lungs. He had profound ARDS. And his wife is wondering, where will it be that when will I have my husband again? And will I have the father of my baby? Look, she's 9 months pregnant. And I told her, I said, Jessica, I don't think he'll be there for your delivery. And I don't think he's going to make it. And, I always couch it. I say, look, I don't know the answer, but I want you to prepare for the fact that people this sick with liver failure, kidney failure, lung failure, cardiovascular shock, and brain down, delirium, it's at 20% in Oregon, that's over 100%. And so we're not perfect at that, thank goodness, and I was wrong. And I always say, I hope I'm wrong. And if I'm wrong, slap me silly. Okay? And that's great, but I want you to be prepared for the possibilities. So their baby, Wesley, comes to my office and we talk often, and he's a good boy. So at the beginning I asked, where are you with regard to your ability to deal with, or how you will deal with, a life-threatening situation? And St. Teresa of Avila, in Fire Within or Interior Castle, is writing about these heroic virtues. And she says that in any trial, we have to meet that trial easily, promptly, joyously, regardless of difficulty, and consistently. I think all the time about these 5 heroic virtues. Can I meet any trial easily, promptly? The third one is a clincher, isn't it? Joyously? Really? Regardless of difficulty and consistently. But all the mystics wrote about begging for crosses. Read them. All the saints talk about this. Christ, where is my cross today? It's 11:59 at night. Christ, I've got 1 more minute to give me my cross today. I need my cross to join on the road to Calvary to you. So yes, joyously. And yet this person carrying the cross in this cartoon is not too happy, is he? He's complaining about the size of the cross. Jesus Christ, God, this cross is too big. Whittle it down for me, would you? And so he whittles, makes it smaller, still too big. He wants it smaller. He makes the cross smaller still. And on the last one there, you can see him whistling Dixie, happy as a clam. Everybody else is struggling until he gets to the ravine. And then, of course, the others come and lay their nice large crosses and walk straight across. So yes, easily, joyously, consistently, regardless of difficulty, promptly. These heroic virtues. And yet I wonder this all the time. And I told this story yesterday, I don't always tell this, but it seemed to resonate with people. When I was a young dad, I was sitting on the edge of the pool. And my daughter said, I want to go up on the diving board. She went up there in a big pink bathing suit. And she was going to go off the high dive. And I was kind of looking at the water, looking back at her, and out the corner of my eye, I saw the pink falling. The pink. She had a pink bathing suit on. All I could see was pink. The pink going, descending. The only problem was, it was over the cement. And so she fell head first, hit that cement, and then flopped into the pool. Unconscious, seizing, 7-inch skull fracture through her foramen magnum on both sides of her skull, blood pouring into the water, and me diving in the water, scooping her out, getting out and carrying her alongside the pool. Eyes rolled up, seizing, my hand going into her skull in the back. It was bad. And I put her down, and I remember beating on the cement, God, why did you take my daughter? And I was just beating that. Others told me what I said later was kind of in my subconscious. This is before I ever read about these heroic virtues. And Taylor was in the neuro ICU. She did make it. She was very scared even to get into a bed afterwards, that she might fall out of the bed. And she is a beautiful 19-year-old girl now at Skidmore College in upstate New York. And she joins me down in Haiti for these mission trips and such. But the thing is that after that, on all kinds of different situations in prayer, I prayed for God to tell me that I would be ready to meet anything like that, the loss of a child, for example, with these heroic virtues. And at the end of the talk, I'll tell you about 2 plane rides that occurred in my life, which I think were God's answer to those prayers. Let's move into some data. The demographics of society shaping secular thought. These data on this slide are really what we need to confront regarding aging. The aging of our population, shown there by decades, is rapidly advancing in terms of those in blue over 65 and those in red over 85. And this is what drives me in my pursuit of critical care, that I, as a geriatric intensivist, that I, having been trained by one of the fathers of geriatrics in the country, Bill Hazard, who's my mentor, have always asked questions with regard to how can we do a better job for our older people. And as an intensivist, I oftentimes provide life support in the way of support for shock, mechanical ventilation, renal failure, liver failure, etc. But it's clear to me as a Catholic, as somebody who very much believes in the afterlife, that just because we have technology doesn't mean we have to use it. And that there are often times when the best decision is when not to use technology. And with regard to age and the decision to use technology, I'm very clear that ageism is not the way to go with regard to this decision. Ageism is the tendency to devalue life at advanced age. And if you are a person of that ilk, chronological ageism, then let's talk to Buster Martin here, who at the age of 101 ran the London Marathon and completed 26.2, which that's actually kind of a timely slide right now, isn't it? Because next Sunday is the London Marathon, and that's the big question right now: is how will they pull that off? But Buster ran this at the age of 101. He's drinking his Buster's Bitter there, if you can't read that label. And many people would say that if Buster gets sick, that he shouldn't have life support because of his advanced age. How can society sustain that? Euthanasia is the action or omission which by intention causes death. This is hugely in the news this week. If you go to nejm.org, which is New England Journal of Medicine.org, or just Google the New England Journal and go to their This Week's Journal, you need to vote. There is an article on physician-assisted suicide, the data from Washington, where doctors write prescriptions to kill people. And there are a pro-con set of articles about a hypothetical patient with pancreatic cancer and asking you your opinion of whether or not he should or should not get physician-assisted suicide in that situation. This practice of euthanasia in the context of the U.S. Conference on Catholic Bishops is in grave violation of the law of God and in violation of natural law if you don't believe in God, since it is the deliberate and morally unacceptable killing of a human person. The Catholic Hippocratic Oath actually states, "I will neither give a deadly drug to anybody who asks for it, nor will I make a suggestion to this effect. Whatever rooms or hospitals or houses I may visit, I will come for the benefit of the sick, remaining free of all intentional injustice." What we have to be able to ensure our patients of is that we have no incentive other than to help them preserve their life. Or, when their life has come to its natural end, that our incentive is to usher in a good death as free of suffering as is possible. So, this is a really critical point, but it does not mean our goal in preservation of life, as this slide states, does not mean that we have to always choose technology in the form of life support. In fact, on this slide, the relationship between, or the distinction between euthanasia and foregoing life support is addressed head-on by the U.S. Conference on Catholic Bishops, when they write, and I quote, "To forego extraordinary or disproportionate means is not equivalent to suicide or euthanasia. It rather expresses the acceptance of the human condition in the face of death." All of us as healthcare professionals have to help others understand this difference. One of the things that drives people to want euthanasia is the worry about excessive use of technology when the person has no likely benefit from that technology. So if we in the room can go out into the world and help others to realize when it is over, or when we need to let God take it in His hands and not use life support, and we won't have people, consuming a gargantuan amount of unnecessary life support when there was no benefit gained from it, then that will help others to not want to fight so hard to go towards physician-assisted suicide. I think that really these outlier examples are some of the reasons that otherwise well-intentioned people end up on the wrong side, on a side that I think is the wrong side of this argument, or better yet, one which ethicists, moralists, and natural law thinks are the wrong side of that argument. So for patients who are suffering in pain, with anxiety, delirium, etc., what do we do in terms of the provision of pain-relieving medications, etc.? This is well addressed in the last talk. I thought you did an excellent job of dealing with analgesia in that talk. And I want to hit head-on this issue about the principle of double effect. When my father-in-law was dying of colon cancer, metastatic colon cancer, and my wife was still in Nashville, but I was up in New Jersey with him in his house, and carried him to his bedroom out of Cornell Hospital in New York. Over the next several days, I was the one administering his narcotics. And I remember struggling with that. He was in a lot of pain. He had tremendous need for morphine, but I knew what the effect of the morphine was going to be in terms of respiratory suppression. So the bright line that we are asked to stay on one side of and not cross is that if the patient is suffering and in pain, then we should relieve that suffering with the technology that we have. In this case, analgesia is the technology, a narcotic. If that shortens the lifespan of the patient because of respiratory suppression, that is not the intended effect. And in fact, this issue of double effect is wholly endorsed by ethicists and theologians. We not only accept, but actually endorse this principle of double effect, that there is no harm or sinfulness when medications are used to achieve comfort, but happen also as a double effect to accelerate death. There's no doubt in my mind that Frank, my father-in-law, who's looking down on us now, probably died a day, maybe 2 days earlier because of receiving narcotics. But he was in immense pain, and I only gave him the amount of narcotics that I was clinically able to discern were treating his pain. Once the pain is covered and you're way out here, that's where you might be thinking, wow, we need to stop now. We're over-medicating. Now we're just suppressing respiration. We can cut all the way back to here and still have the pain covered. You see my analogy? So that's something to consider. And this issue of double effect euthanasia, so our challenge is striking that bright line. Now let me give you a patient example that I didn't invent. This was published in the New England Journal of Medicine a few years ago. And at the end of this patient example, I'm going to actually ask you to raise your hand. There's no right or wrong here, but let's just, out of curiosity, see where everybody lies on the spectrum of decisions here. And after you raise your hand and vote, then I'll show you what the rest of the world voted, because this case was put to a vote globally by the New England Journal of Medicine. And the third slide I'm going to show you here are the results of that. And I'll tell you that there were multiple different directions that people voted. Okay? So wherever you raise your hand, you're going to have some people agreeing with you on the third slide. Right? So this is a guy who presents with a fatal, intractable cranial bleed. He's unconscious, is placed on life support. After that, they find this, what we call linitis plastica. It's an incurable gastric cancer. And everybody gets together, the neurologists, the surgeons, the oncologists, and they say, there's nothing we can do. This is futile care, and there's no way for us to solve this man's problems. He's going to die of the bleed in his head, of the bleed from his cancer, of the cancer. This is a fatal situation. After 21 days on life support, the whole medical team says, this is futile, what are we doing? We're prolonging death, prolonging the inevitable. So they go to the mother and the brother, who both think, withdraw support. This is over, I agree. But the son, who lives 1,500, 2,000 miles away, and has been excommunicado with the father for many years, doesn't feel comfortable with that because he doesn't know anything about his father, hadn't talked to him in years, and he disagrees. But the son is the legal next of kin. Okay? So now the guy's on life support that nobody except the son, who doesn't know anything about the father, says, let's let him die a natural death. Now, then a guy comes, a counselor, who knew the guy, and says to them, I talked to him, and he told me, when my time comes, I want no aggressive care. Do not give me life support. Help me die a dignified, comfortable dying process. So, do you think that we should go with the son and keep him on life support? Do you think that we should go with the medical team and the patient's preferences, who said no life support for me in the face of an intractable disease? Okay? And do you not know and you want to turf it to somebody else?
I hope the sun visits then.
Yes, we hope the sun visits. Well, here's where the world stood. The blue is the majority in North America, Europe, Africa, and Australia, which is withdraw life support. Notice I did not say withdraw care. That's one of the other 8 tenets of end-of-life communication. We never say withdraw care. We say withdraw support. We never stop caring. Right? And yet all the time in hospitals you'll say, we're going to make them a DNR, withdraw care. Left turn in our communication, big time. Anyway, you can see that the minority answer there was aggressive care and ethics consult. But most of the places were in favor, the majority anyway, of withdrawal of support. That is where I would stand, by the way. I would be in the blue, which is what the majority of you voted for. In dealing with patients, always I am there to serve the patient. I very much view myself as a servant of the family too, no question. And what a privilege that is to enter into that holy time with them in critical illness and end of life. But if I have to choose, if there's a disagreement between the family and the patient, always I have to go with the patient. That is my primary obligation. And so in this case, I seek truth. And if I know the truth, or if my best approximation of the truth of this patient's wishes are to be removed from life support and have a natural dying process, then I have to go with that. Even if the law puts the son in the place as the surrogate, I have to go with what I know is true about the patient. And I would stand up for that 100 times out of 100, I hope. And if you ever catch me not doing that, then call my bluff. So a person has no moral obligation to use extraordinary or proportionate means in preserving his or her life. And what is proportionate means? Proportionate means, as defined by the U.S. Conference on Catholic Bishops, those that in the judgment of the patient or the medical team offer reasonable hope or of benefit and do not entail an excessive burden or impose excessive expense on the family or the community. Clearly that word expense is not just referring to money. There are all kinds of emotional and other types of expenses which we have to factor in. So in terms of technology, I also want to make the distinction that there is no moral difference between withholding and withdrawing life support. We have to formulate moral judgments about life support. One must consider the innate dignity of the human and the purpose of the medical care. And even with regard to nutrition, which on this slide I will address in a couple more, hydration and nutrition are not morally obligatory when they, for example, cannot be assimilated into the patient's body. If the patient has so much gut edema that they can't absorb it anyway, then we do not have to be morally obligated to provide that. In the majority of circumstances, of course, we do provide nutrition, and we do make sure that is something that is the last thing we would withdraw. But there are numerous studies that show, for example, no increased survival with tube feedings in severely damaged or demented patients. In this case, no prevention of pressure ulcers with feeding, no reduction in risk of infections, no improvement in functional status. Just giving you a couple of examples of the flip side of the nutrition argument. And today at the Pulse discussion at noon, which we're about to get into, and I started a little late, so I'm going to try and wrap it up here. I know that we'll get into this decision on the Pulse documents where people, I think, are too readily checking the no food, no antibiotics checkboxes. And I'll go ahead and tell you my answer there is that I think those Pulse documents are helpful, except when we are too pushy to get people to renounce any form of support, including food, water, and antibiotics. Those to me are the most sticky points about the Pulse documents. But even in the CMA publications with regard to nutrition, in the CMA publication it says nutrition and hydration, even when artificially provided, are normal care due to a sick person when not burdensome to him or her, but we should distinguish between active dying from those with weeks or months to live. It might be appropriate to provide assisted nutrition and hydration for the latter, those who are actively dying, and maybe not provide nutrition and hydration for those who are actively dying. Key there being, you have to define what's the word active. It might mean hours, it might mean a day, something like that. But that's taken straight out of the Lineker Quarterly, which is a publication of the CMA. And the way I can conclude this area for you is this. On one hand, avoid insistence on useless and burdensome technology when the patient may legitimately wish to forego it, or if it's not indicated. On the other hand, avoid withdrawing technology with the intention to kill. And this issue of paging Dr. Death, I can go quickly through this because I've already addressed it. This was the movie about Kevorkian. You remember Kevorkian? We had on the headlines of Newsweek a couple years ago the case for killing Granny, and recently in Massachusetts, of course, this was posed to a vote, which failed with regard to mail-order prescriptions for suicide drugs. It's kind of scary that in this world we have people who are posing and serving as paid exit guides, where people like this gentleman, Dr. Edgebert, actually help people to buy online a bag to put over their head, to pulled down over their head and filled with helium, where they watched them twitch and turn blue for 5 to 10 minutes and then die. This is an active way happening in society that this gentleman and others are helping people to die. And even with people with depression, an untreated and certainly modifiable disease. Instead of that, I think that in the face of death, it is very humbling and edifying to witness courageous men like this, who, while facing ALS, Lou Gehrig's disease, he asked to marry his partner of many years so that they would have a legitimate marriage for their son, who you see on the bottom picture. And he writes to me, "Doc, love wins," on the ICU pad there after their marriage. Instead of asking to die earlier and not have those precious 6 months that he had of marriage with his son and his wife, he did have that precious 6 months. And it helps me to try and remember how much more necessary it is for us, all of us in this room, and your friends and other healthcare professionals, to provide patients with comfort, boundless kindness, and love. This service of God of Matthew 25. As Mother Teresa always said, the gospel on 5 fingers. You did it to me. Mother Teresa taught that to her sisters, the missionaries of charity. I was just in India, in in Calcutta, and I learned this from the sisters there. You did it to me. Gospel on 5 fingers. Exactly what we need to do in our lives as healthcare professionals. So let me close with the 8 points about communication, and then the last 2 stories, and I'll be done. First off, the spiritual history. I've already taught that to you. Secondly, emphasize it as a privilege to care for him or her. Third, we are gathered to serve the patient, not primarily the family. The patient is first, the family is second. Both there to be served, but in the right order. Next, do not ask the patient or family, do you want everything done? The word everything is a loser. Okay? If you have a cold, I don't give you chemotherapy. Okay? Only what's appropriate. Discuss withdrawal of support, not withdrawal of care. We've already covered that one. Refer to the burden of care instead as the honor and privilege of care. You hear people talk about the burden. Patients are never going to be a burden unless you think of them incorrectly as such. The last 2, reassure the family and the patient that we will never abandon them. There is a tremendous sense and worry about abandonment when we go towards end-of-life care. And we change the ladder that we're climbing from the ladder of cure and put it over here on the wall, which is the ladder of comfort. When we make that transition from cure to comfort, that's when people think, oh, they're going to leave me now. I'm on my own. So reassure them. And then the last one is the flip it. Okay? I won't read all these to you, but I will make a plug for you or a tip to read Jacques Philippe's books. These are little bitty books, this thin. You can read them in 2 days easy. Jacques Philippe, the author at the bottom of this, talks about the bread of tears in his books. 2 of them are listed here. Interior Freedom is a phenomenal little book. I have 20 copies of this book in my office at Vanderbilt all the time to give to students who come in and talk to me. Interior Freedom. I just read Call to Life, and there's another one I just read as well about the Holy Spirit. But check out his little books. Now, in closure, look at this statue. This is the most viewed statue in the world every year, the Pietà. And you see a human, Mary, not divine, but a human, holding her child, bloodied up, back and front, arms and legs completely covered in wounds from the scourge and the flogging, hole in his side, who died that gruesome death there. And she's holding him, and what do you not see on her face? No anger. Mary had no anger there. Sadness, yes, but in the face of the Pietà, you see no anger. And that speaks everything to me about our approach of death and the 5 heroic virtues. That we have to meet even a tragedy such as this, or the pink bathing suit daughter falling to the cement. All of those trials have to be met joyously, promptly, regardless of difficulty, consistently, etc. And so, after having prayed for that many times, I was on an airplane once going up to the Northeast, and a woman in the seat next to me, and usually I don't talk on airplanes, I kind of get in there with my books and do my own thing, but for some reason we got into a conversation, and God, in the most unexpected of times, answered that prayer I'd been saying for all those years. And she told me this story, and I don't embellish it or change it a bit. She said, I had a son, one son, years ago, before the time of cell phones and modern day technology, and he was everything. The quarterback, the big man on campus, the president of the student body. And on the day of his high school graduation, he came back to the house and gave me a hug. He said, Mommy, I love you. You're everything to me. I'm going to go out with my friends, and I'll come back later and we'll celebrate some more. And he got in the car and drove off, and the moment that the car was out of sight and the door closed, and she went to kneel down to pray, God told her, telling me this on the airplane, God told her, you will not see your son again in this earthly life. And the key is what she said next. I immediately began to pray in thanks. Were you angry? No, I was not angry. Why? Every day with him had been a gift. I began to pray in thanks for every day I had with him. And 2 hours later, the policeman came to my door. They knocked on the door and opened it and said, your son was killed in a car wreck 5 miles away. She said, I knew it already anyway. And she knelt down and probably looked a lot like Mary at the Pietà. But she had no anger, and she met that situation with the heroic virtues without question. And then I knew that it could happen, that a regular human could do that, not just a Mary. And 2 weeks later, I was on a second plane ride. And on that day, the man sitting next to me was gushing with tears the entire way back. He was about 32. And I kept getting stacks and stacks of napkins from the stewardess and giving them to him. And at the descent, he said to me through the tears, I'm so sorry. I was going down to Atlanta today for a business meeting, and when I arrived, my wife called me and told me my son had been run over. And so now I'm in the plane to go back, and I don't know what happened. He didn't know anymore. And we started talking, and I was able to do my best to piece together a response to him based upon the need that you have now of taking this concept of death, this baptism, the theological pieces of it, the human pieces of it, and teaching other people how to embrace the moment and to direct towards that moment of death as a transition in life and not as an end. And I think if we approach it like this story that we're told, this golden string story, imagine that you were on the edge of the playground and your child or your niece or nephew or whatever though, a child comes to you and says, look, mommy, aunt, brother, sister, whoever, look at this golden string I found. Isn't it amazing? Can you hold this golden string? Hold it for me while I go play and make sure nothing happens to it. And now you hold that string. Now you have it in your hands. And the child turns around and runs back onto the playground. As that child that you know is running back onto that playground, and now you are in this story holding that string, how much is that child worried about that string? You know the child. Are they worried at all about the string? Not at all. Why? Because you got it. And how much better is our Father going to handle our golden string than you can handle that kid's? So why are we worried? Thank you. She said, what was the question? What is your name? My name is Eclete Simeon, and I have a question. In the middle of her bleeding knees, her wounds on her rear end, etc., she said, when can I make my first communion? So she asked me. 2 days later, we flew her out to Port-au-Prince. She's now with plastic surgeons, wound care specialists, and physical therapists. And on the plane ride over, I took pictures of her feet. I can show you these. I'm not making this up. She has 2 central lesions in the dead center of her feet. Thank you.